telling a story with your clinical HIV testing data. My name is Audra Tobin Severson. I respond to she, her pronouns, and I proudly serve as a senior capacity building specialist at San Francisco Community Health Center's Chicago office, located in Chicago, Illinois. Today, I am honored to serve as your presenter for today's session. During today's session, audience participants will have the opportunity to review the importance of clinical HIV testing data and how to utilize that data to measure progress and barriers towards testing implementation at a clinical site. Together, we will review our national Ending the HIV Epidemic strategy and how your clinical HIV testing site plays an invaluable role within the bigger picture objective. We will then discuss strategies for tracking clinical progress by optimizing your agency's electronic medical record, also known as an EMR, to track and measure HIV testing and linkage to care activities and outcomes. After that, we will discuss the many ways in which clinical testing sites can disseminate and share their HIV testing stories. We will wrap up today's discussion with some closing thoughts, and of course, we will open the floor for Q&A and networking. So welcome. As I mentioned earlier, my name is Audra Tobin Severson, and I respond to she, her pronouns. I serve as a senior capacity building specialist at San Francisco Community Health Center Chicago office. As many of you may know, San Francisco Community Health Center Chicago office serves as a Midwest capacity building assistance provider under Track A. Track A specializes in technical assistance and training for prevention for individuals living with HIV, and of course, clinical HIV testing, which is the theme that brought us all here together today for this morning's session. So a little bit about myself. Personally, I possess 7 years of clinical experience working in inpatient, outpatient, and emergency department settings, including a level 1 trauma center. My HIV testing experiences include direct patient services, as well as management and oversight of various testing models and workflows, including targeted, dedicated, and opt-out testing models. The U.S. Department of Health and Human Services has implemented a national plan for America called Ending the HIV Epidemic. The objective of this plan is to reduce new HIV infections in the United States by 90% by the year 2030. Ending the HIV Epidemic, a plan for America, includes 4 key strategies which together could potentially end the HIV epidemic. Because this session's theme is clinical HIV testing, we will primarily be focusing on the diagnose strategy of ending the epidemic, which is the green bar at the top of your screen. According to the Centers for Disease Control and Prevention, also known as CDC, in 2018, about 14% of individuals living with HIV are unaware of their positive status. 14% of individuals living with HIV are unaware. Do you hear that? That's where clinical HIV testing comes into play. So in an effort to identify the 14% of unknown infections and to measure progress towards ending the epidemic, CDC proposed the following diagnose activities for agencies that they are working in collaboration to optimize and increase clinical HIV testing in accordance with CDC's testing guidelines, of course. So there are a number of proposed diagnose activities outlined, but the 2 that we're going to focus on today are strategies 1A and 1C. Why are we focusing on the proposed diagnose strategies 1A and 1C? I will tell you why. Because both strategies are related to EMRs. Remember, EMRs stand for electronic medical records. And EMRs are the hidden key to optimizing and increasing clinical HIV testing. So let's talk about strategy 1A of the diagnose strategy. This proposes clinical sites to modify their EMR to routinize the offer of HIV screening by screening all patients at least once, regardless of their risk, and unless they decline the test. This proposed activity, in essence, is it's really sustaining HIV testing as part of routine medical care for patients, which could potentially yield to a decreased percentage of unknown infections in the United States. Strategy 1C proposes clinical sites to modify their EMR to routinize the offer of annual screening for those at ongoing risk of HIV. The proposed activity is yet another imperative strategy to routinize HIV testing within a clinical setting, as we are optimizing our existing technology resources to identify opportunities to test patients. Thus, we are potentially decreasing the overall percentage of unknown infections in the United States. So what we have here is a list of suggested HIV testing variables to be built within an EMR to measure progress and barriers towards clinical HIV testing implementation. So let's review what those test tracking variables can look like and how they can be built within your EMR. So some variables that we want our EMR to collect. We want our EMR to collect whoever the ordering provider is. It's important to know who the ordering provider is. One, because we need to know who's responsible for this HIV test. We need to be able to celebrate this ordering provider because they tested someone for HIV. And we also might need to circle back to this ordering provider in the event we need help connecting with the patient or for linkage to care purposes. There's so many reasons why we need to know who is ordering this HIV test, and that's just one of the very few tracking variables that we will be collecting in our EMR. Another variable to collect is location of HIV test. Now, not all clinical sites offer HIV testing throughout their entire system. This is also known as system-wide testing, and it's important that we keep that in mind. In fact, it's important that we keep in mind that testing looks different at almost every clinical site, which is why we collect both the qualitative and the quantitative data to make sure that we are getting a full grasp of the entire story. So in regards to the qualitative data, tracking the location of the test, if your agency isn't testing throughout an entire system or doing system-wide testing, we want to know the exact department or the exact location of that test so that we can better understand what testing looks like in that specific location. And that location can look like an outpatient location, it can be an inpatient floor, it can be a department. It can occur at a location can happen at any point, anywhere throughout a clinical setting, and that's something that we need to be tracking. We need to be tracking the date of the diagnosis for linkage to care purposes and as a starting point. We need to be tracking the number of declined tests by a patient, also known as the number of opt-out tests from a patient. It's important to track the number of patients who opted out of an HIV test because that's a part of data that helps us fill in the testing gaps and tells a story. We need to be tracking the number of repeat HIV testing. Per CDC's revised recommendations, repeat testing is recommended for persons at high risk for HIV. And again, that's a piece of data that helps us tell our story about who we are testing and why we are testing them. Our EMR should be collecting the number of confirmed HIV negative test results. This is an important tracking piece for a number of reasons, but to get to my main point, tracking the number of negative test results will help you to determine which patients are good candidates for prevention referrals and even services such as PrEP, all of which could be integrated within a clinical HIV testing workflow. An EMR can also track the number of confirmed HIV positive test results. We need to know our testing program seropositivity rate. We need to know who is testing and when, who is testing positive and when. Our EMR needs to be tracking the number of acute HIV infection test results. To be clear, tracking the number of acute HIV test results is a subset of the previous bullet. And if we have the capacity to conduct fourth generation testing that's capable of identifying acute infections, then we should be tracking that information and monitoring our response to those acute infections that are identified through our testing programs. Another variable that our EMR should be collecting is the number of indeterminate HIV test results. Unless it's built within your EMR, viral load tests are not typically reflexed by an indeterminate HIV test result. Thus, clinicians need to know when a viral load has to be ordered to confirm a diagnosis for quality measures, for tracking purposes, or for linkage to care purposes. And just for clarity, this is a list. This list is comprised of data collection examples from some known testing funders who are all cited at the end of this presentation. So stay tuned for those citations. Okay, so what we have here is a list of some suggested HIV performance outcomes to be measured by an EMR to determine progress and barriers towards testing implementation. So those performance measures that can be built within an EMR would include percentage of patients tested for HIV. We really want to know what percentage of your patient population is being tested at your clinical site. We want to know what's going on. Your EMR can also capture percentage of patients eligible for repeat testing. And just to be clear, this is not a subset of the previous bullet, that's just a formatting error. So I just want to be clear about that indentation over there. But anyways, for multiple reasons, collecting percentage of patients eligible for repeat testing is so important because we want to know the proportion of our patient population. We want to know who is identified as high risk, and we want to know if we're testing them. This data will help us better understand who our high-risk patients are, their trends, and how we can better meet their needs. We also want our EMR to capture the declination rate, which would also known as the percentage of patients who opted out of an HIV test. We want to know the full story of HIV testing. We don't just want to know who tested positive. We want to know who tested negative. We want to know who opted out of the test. We want to know the full story so that we can get a full picture idea of what it is that we're working with at our agency. False positivity rates is another performance measure that we should be collecting. This data outcome will help us understand testing trends and any barriers or challenges that exist within testing technologies. Positivity rates is another performance measure an EMR can produce. Acute HIV infection rates is another performance measure that we should be monitoring. Repeat testing rates. An average CD4 count at the time of a patient's diagnosis. And this measurement could help us understand, on average, at one point in the patient's disease progression, are we diagnosing them? Another variable that we should be measuring in our EMR is the average viral load count at the time of a diagnosis. And the same point applies to this final bullet and helps us ultimately to measure how long it takes for a patient to achieve viral load suppression if they're initiated on antiretroviral therapy. Again, for clarity, this list is comprised of data collection examples from some known testing funders who are all cited at the end of this presentation. To complement HIV test tracking activities, here we have a list of some suggested linkage to care tracking variables to be measured by an EMR to determine progress and barriers towards testing and linkage implementation. So we're starting off with date of diagnosis. Again, that's a great starting point. We need to know that date of diagnosis. We also need to know the date the patient was notified of their test result. And this is especially for quality assurance purposes. Sometimes patients are discharged without even being informed of their HIV test results. So it's imperative that we track the date the patient is notified of their test results. In addition, for a number of other reasons, but that's our primary reason that we're focusing on today. Your EMR should be tracking your patient's CD4 count, which is a requirement for if a patient is initiated onto antiretroviral therapy. And that same goes for viral load, HIV RNA count, and a patient's genotype. Those are all requirements for antiretroviral initiation and can be collected by your EMR. Okay, moving on. Your EMR should be collecting the date of the scheduled appointment. So when you meet with a patient who has been tested positive for HIV and you are trying to engage with them and link them to care, you are scheduling that first medical HIV appointment, right? And what we need to do is document that date. And the reason why we're documenting that date is to ensure, is to measure progress towards linkage. We want to see if that patient was in fact linked to their medical appointment that was initially scheduled. And if so, how long did it take them to attend that appointment? We want to collect the date antiretroviral therapy was initiated. Ultimately, this variable will help us measure how long it takes for a patient to be virally suppressed if they initiate antiretroviral therapy. Again, for clarity, this list is comprised of data collection examples from some known testing funders who are all cited at the end of this presentation. So what we have here is a list of some suggested linkage to care performance outcomes to be measured by an EMR to determine progress and barriers towards testing implementation. All right, outcome of a patient's scheduled linkage to care appointment or their scheduled HIV appointment. So you met with a patient after they tested positive, they accepted your services, they're ready to be linked to care. What was the outcome of that appointment? Did the patient attend the appointment? Did they make it to their appointment within the 30-day recommended time frame? Or were they linked to care sooner than that? Was the patient no-show? Did they not attend their appointment? As a result of that, is a patient considered lost to follow-up? And if so, should the patient now be reported to DIS or the health department or some sort of lost to follow-up services? Those are some areas that we really want to start thinking about in terms of scheduling your appointment and the appointment outcomes. We really want to know what's happening at these appointments and how long it takes for a patient to get there and what the outcome of it is. Okay. Viral load suppression rate. Of your active patient populations who is engaged in antiretroviral therapy, about what percentage of your patients have achieved viral load suppression? Another linkage to care performance measure to monitor is the patient's average time to their first attended appointment, and we talked about that. How long does it take for a patient to attend their appointment? Perhaps maybe there's an opportunity to re-examine what your clinical workflow looks like. Perhaps there's a way that we can speed up our response in the linkage to care workflow in some way, shape, or form. We also want to monitor the patient's average time to antiretroviral initiation. On average, how long does it take for a patient to be ready for antiretroviral therapy? And for clarity, this list is comprised of data collection examples from some known testing funders who are all cited at the end of this presentation. Okay, now that we've built HIV and linkage to care data, tracking, and performance measurements into our EMRs, and all the systems are working fantastically and running and everything's going smoothly, right? Because that's what always happens when we're implementing HIV testing through an EMR, through an EMR approach, I should say. What do we do with all this testing data that we have now? What do we do with it? We tell our story. We study our data and we know our data. When people ask what your seropositivity or linkage to care rates are, you need to know that information. You need to be fluid with your data, almost as if it's a second language. Identify testing trends and report on them. Identify the gaps in your services and clinical workflows and brainstorm solutions to close those gaps. Identify the successes and showcase them loud and proud. But who do we share our stories with is the question. First and foremost, we need to maximize our internal resources and promote our HIV testing stories internally. As I mentioned in my earlier slide, it is imperative to present both the qualitative and the quantitative data. Acknowledging your testing champions and celebrating their efforts. We need positive reinforcement, people. We have to acknowledge when good things are happening. We got to give people a high five when needed. Presenting patient case stories, case studies, linkage to care stories and outcomes, especially for providers who are working in emergency department settings. Those clinicians aren't usually following up with their HIV identified patients. They're working in an emergency department setting. They're not following up with those patients. So having your HIV team circle back to those testing clinicians and telling them the success story, telling them the linkage to care story, letting them know of that patient story, who they tested. Adding some life to the data, humanize your data, and let your ordering clinicians know all the incredible work that's getting done thanks to them sending that test order to the lab. Okay, who else should we be reaching out to? We need to be reaching out to our marketing staff, our internal marketing staff. We need to be disseminating information through social media platforms. We need to be sharing information through internal announcements and emails. Promote ourselves within our agency. Present your story to grant writing and program development staff. The funding staff. That's the radar that you want to be on. You want these people to know your testing story, especially in the event they may hear of a testing funding opportunity. They'll know right away, okay, we have a great testing program here and we have a lot of data to support it. Present your story to a new staff orientation event. And hear me out on this one. If you were to integrate yourself within a new staff orientation, which presumably occurs somewhat regularly or quarterly on some sort of schedule, if you were to integrate yourself in that agenda, say get 2-3 minutes of the new caregiver's time of the agenda to really promote HIV testing, advertise your testing policy at your agency, and let them know the amazing impact that you're having in your community and the epidemic that we're striving to end. If you were to promote through your new caregiver orientation, you're capturing newbies who are just funneling through your system and who might potentially spread the word. And also that's just a new opportunity to catch people when you have, it's just a great opportunity to get a captured audience is at a new caregiver orientation. Okay, moving on. So you need to prioritize your efforts with staff who are also involved with clinical HIV testing, who are involved with the patient workflows, with the testing workflows. And who could those people be? Clinicians, obviously. Those people could also be the laboratory staff. Once someone gets tested, that specimen gets taken off somewhere and then something happens to it eventually. So what's happening behind the scenes? Are those the scenes that we need to be part of? Should we be engaging with those people behind the scenes? Yes, we should. We should be engaging with everyone who is part of and engaged with the clinical HIV testing workflow. So that includes, in addition to clinicians, laboratory staff, it could also include registration staff, who are the folks that are collecting the general consent to care. Another opportunity that you can present to would be medical and nursing students, especially at learning institutions or for new caregiver orientations. We could be focusing our efforts on social workers, the quality review committee from our agencies, executive level or C-suite managers such as CEOs, CMOs, or COOs. And of course, we should be promoting our stories to our executive board. We need to let leadership know what's going on and what it is that we're doing and achieving here. Okay, another mechanism of dissemination would be sharing externally, right? So who do we reach out to when we're sharing our testing data externally? First and foremost, we share it with our state and local health departments. Inform your stakeholders, inform your health departments of the testing efforts that's occurring at your agency. Everyone needs to know what's going on, especially in the event a local health department or state health department needs to follow up with you regarding a particular patient, regarding a particular data variable or case surveillance report form or any reason why a health department might need to re-engage or engage with a patient, they might need to touch base with you first. So having that relationship with your health department and keeping them abreast of all the amazing work you're doing is so important and really helps close the loop with telling your story. You also want to tell your story to current funders, especially if we want to keep, especially in the spirit of sustainability and funding purposes. We want to keep our funders updated and let them know the amazing work we're doing thanks to their support. We also want to focus our efforts on potential funders, and the same applies for potential funders. We need to promote and sell ourselves to our funding sources for sustainability purposes. We need to promote ourselves to HIV community planning councils, and that can include HIV community advisory boards, health department planning councils. Those committees are some of the biggest champions that we have that may or may not be affiliated with your agency. Those are external stakeholders that we have to hold on to tight. Those are our big champions that want to hear our story. So it's important that we always keep them abreast of what's going on. Additional community stakeholders might include church leaders, politicians, people who have a voice in the community and should be aware of testing activities that's occurring in their communities. And then, of course, we have conferences and publications. Those are some of the obvious ways of dissemination, right? But is it really easy? No, it's not easy. More often than not, you need a dedicated person disseminating this information, creating a story, making it look pretty and getting it out there. But I tell you what, once you get your story out there, it will be out there for the world to see, and so many will be able to benefit from your lessons learned, your promising practices, and the impacts that you are making within your community. Just thanks to including HIV testing as part of routine medical care. So another strategy of maximizing your EMR's data is to use your data to understand barriers or gaps within your agency's testing model to determine areas of improvement in, for example, HIV testing workflow. So our data will help us understand the ins and the outs of our existing clinical workflows. So with that said, I want you to ask yourself, based off your testing data, where do you see successes, gaps, or areas of improvement? Consider, for example, a patient's general medical consent. Consider what that workflow looks like when a patient consents to care. Did the patient opt out or decline of the HIV test in their general consent to care? If so, was that patient's declination for an HIV test documented in the EMR? If the patient's decline for an HIV test was in fact documented in the EMR, but an HIV test happened to have occurred on that patient, perhaps some quality assurance and quality improvement activities may be needed to better understand why an HIV test actually took place despite the patient declining or opting out of the test. Essentially, my point is that cross-referencing your supporting documentation, which should be stored in your EMR, and cross-referencing that information with your testing activities and services, those are great quality assurance and continued quality improvement activities. Another example considering, another workflow example considering would be a laboratory workflow and considering the test result turnaround time. Is it efficient enough? Is the lab's HIV test result turnaround time complementary of the existing clinical workflow? Perhaps another EMR modification needs to be integrated within the computer system to create a reflex lab order to confirm any diagnosis resulting in faster test result turnaround time. Does your laboratory have enough capacity for routine opt-out testing? Now think about that. Think about how many people might be getting tested in a day thanks to opt-out testing. Can your laboratory department or your lab that you're outsourcing to, can they handle all that specimen that's being tested? That's a realistic question that we need to consider. especially for the people behind the scenes, we need to bring them to the front of the scenes because their workflows are all just as much relevant as to the workflows on the front lines in the emergency department or in the outpatient location, wherever that test is occurring. In regards to linkage to care workflow, consider, for example, your HIV positive response. Are patients being notified of their positive test results? Is there an opportunity is there an opportunity within your clinical workflow to notify patients of their test results sooner? After receiving diagnosis, are patients being connected with a linkage to care staff person within an appropriate amount of time? Is it deemed an appropriate amount of time by the agency or by CDC's recommendations? These are all items that we need to consider in terms of workflows, quality improvement, and perhaps even adjusting policies to ensure that workflows are complementary of one another and are aligned with CDC's recommendations. Consider, for example, missed opportunities to test a patient for HIV. Missed opportunities to test a patient for HIV sheds light on the total number of medical visits that a patient experienced, but for some reason was not tested for HIV due to either a systematic error or a human error. And a human error, as it relates to missed opportunities specifically, an example of a human error might be when a clinician bypasses an EMR prompt that tells you to test a patient for HIV during that medical visit. That could be considered a human error in missed opportunities, excuse me. Analyzing a clinical site's missed opportunities may yield to additional questions worth exploring for continued quality improvement purposes. Some questions may include, did the patient receive a late diagnosis, an AIDS diagnosis at the time of their HIV test result? If so, how many medical visits did that patient encounter at your clinical site prior to receiving their AIDS diagnosis? How many missed opportunities were there to test that patient before they received their AIDS diagnosis? If so, I want you to also now consider the patient's total number of previous medical visits in which the patient may have been treated for HIV-related symptoms or conditions such as tuberculosis, meningitis, pneumonia, cancer, other opportunistic infections that could have been a result of a late or AIDS diagnosis. Now consider all of those services that are being provided to a patient. Now consider the resources that could have been saved, potentially saved, had we just routinely tested this patient for HIV. When testing your patients for HIV, it is imperative that we take into consideration our latest pandemic, COVID-19. Some testing trends and related questions that are worth considering when testing your patient for HIV may include when testing your patients for HIV, is there an opportunity to test a patient for COVID-19 as well? Also known as dual testing, is there an opportunity for that to occur? Based off your HIV and COVID-19 testing efforts, what testing trends are you finding? Are you experiencing low or high testing volumes? If so, have you considered why that is? Perhaps you're experiencing high testing volumes because more people are inclined to go visit their provider during a pandemic, because of a pandemic. Perhaps you have low testing numbers because you have a lower patient volume because there's less people inclined to leave their house when there's an executive shelter-in-place order within your jurisdiction. There's numbers of reasons of why there's low or high testing volumes among your patient population, and that's something that's worth exploring through your data. Another consideration is co-infection testing or linkage to care trends that are worth considering would be any similarities or differences between mono HIV or mono co-infected or co-infected patients. Are there any chief complaints, any similarities, differences that you see among HIV positive or COVID-19 reported patients or identified patients? Is there a scale up in HIV and COVID-19 infection diagnosis? Is there a scale up in acute HIV and COVID infection diagnosis? These are all questions that we should be asking ourselves, especially if we are testing HIV and COVID-19 at the same time. Based off your findings in the past clinical HIV practices, are there opportunities to replicate any HIV promising practices that can be applied to COVID-19 services? So some promising practices that could be potentially applied to COVID-19, and this is just for some brainstorming purposes, but let's start off with testing. Are there internal workflows or patient counseling strategies that can be replicated from HIV to COVID-19 services? What about linkage to care models, rapid response models, patient navigation, peer navigation? Could any of those services practices be replicated and applied to COVID-19? And what about surveillance? What about DIS and partner services? And working with our health departments to track and to identify people in need of services. These are all considerations that are worth thinking about, especially as we're trying to figure out two epidemics at the same time. In closing, each clinical HIV testing site plays a significant role when it comes to addressing the diagnose strategy in our national plan of ending the HIV epidemic. By implementing CDC's HIV testing strategies to utilize your EMR to track HIV testing variables and performance measure outcomes, we will be able to better understand the gaps, the barriers, the successes, as well as behaviors and beliefs around routine HIV testing implementation. And of course, we share our testing story. As referenced in earlier slides, below is a citation of HIV testing funders and cycles that have supported said data tracking and performance measures in this presentation. And I would just like to thank our incredible funding sources for leading the way and leading us all through this incredible journey. And we'll be circling back to Q&A momentarily, but for right now, I would like to remind audience participants that we aim to be your trusted Midwest capacity building assistance provider. And we offer our technical assistance training and support at no cost to partnered agencies. I'll repeat, we provide our technical assistance at no cost to partnered agencies. So for networking questions, concerns, or if you'd like someone to just brainstorm clinical HIV testing with, I welcome you to contact me via email, and I look so forward to connecting with you in the future. Well, while we have a captured audience here who, as I presume, are either testing or interested in clinical testing, I'm wondering if folks are seeing any trends among COVID-19 and HIV testing, any diagnoses. Are we seeing any trends among acute infections? I really would like to hear what folks are hearing or what folks are seeing with the boots on the ground. Okay, so we have Amanda from Maytech. Working with federally qualified health centers, they're often limited by what their EMR can integrate or capture. Any tips you've heard about working with this one to capture data on risk, such as IDU, STI history, might trigger a BPA, which is also known as best practice alert in an electronic medical record for annual HIV screening. Yes, so what Amanda's asking here is, what tips do we have on identifying what we would consider as eligible patients, right? So we would be building within our electronic medical record almost as if it's not a formal name, but an eligibility criteria to identify specific patients with a specific history, medical history, risk history. If you're looking to really identify or screen a specific population within your EMR, there are ways to build your EMR in order to identify who those patients are as soon as they're registered and as soon as they appear within your health system. As far as the nitty-gritty how-tos for a specific EMR, that's something that I would be happy to connect with you separately in a private conversation because, well, there's many EMRs that are out there and I am not an expert in all of them, but I would love to work with you and to network with you and to really reach out to other clinicians who are using the same EMRs as you are and try and bring folks together so we can provide a peer-to-peer learning environment at some point in the future. I think that would be an opportunity. So if that's something that folks would be interested in, is perhaps even connecting with other peers who are utilizing the same electronic medical records, or who are trying to implement similar testing models within their clinical setting. If connecting those providers with one another based off of those similarities, if that's of interest, we would be happy to explore that in our upcoming years. Thank you for your question, Pamela. Are we seeing trends in acute HIV infection? For those of you who were able to join our clinical HIV testing on day one of our symposium, Sustaining Clinical HIV Testing Amidst a COVID-19 Pandemic, we had the amazing opportunity to hear from 3 different health institutions: University of Chicago, Henry Ford Health System, and Access Community Health Network. Our presenters from University of Chicago, Drs. Petrick and Dr. Stanford, both are from infectious diseases and emergency departments, and they did a co-presentation about their findings as a result of dual testing for HIV and COVID-19. And as a result of that, University of Chicago reported that they are seeing actually a scale up in acute HIV infections and COVID-19 infections, co-infections. So that is something that is happening in Chicago, and it is actually, it's not even fresh off the press yet. It's actually in the press. University of Chicago is currently in the process of publishing that information. So we were very fortunate enough to hear that data because it is brand new and it is really, it's really what's happening with the boots on the ground on the front lines in the city of Chicago and some of our most highest prevalent areas in the city of Chicago. Thank you for that question. And Tina, just to confirm, we see the Q&A slide. Thank you for putting that up.
Awesome, you're welcome. We got it in the end.
Any other questions related to workflows related to integrating HIV testing through an automated EMR approach? Questions regarding any examples that I had mentioned throughout the presentation of potential strategies of optimizing a workflow through an EMR by perhaps integrating EMR modifications such as a BPA, a best practice alert, which is a prompt for providers who are in the EMR system and who are seeing their patients and who are capable of ordering an HIV test. There's a number of EMR modifications that you can make to enhance or optimize a clinical workflow, but that was just one example. Another example that was suggested in this presentation is perhaps in the event there's an opportunity to speed up or enhance the result turnaround time from a lab department or a laboratory site that you are outsourcing to. Perhaps there's an opportunity to reflex any lab orders to keep the clinical flow moving, right? To keep the blood work going and to make sure that that screening algorithm doesn't stop and that we do get to a diagnosis if in fact that's what it is that we're screening. Any other comments or questions that we might have? It's a lot of information. But ideally, the essence behind this, the whole point behind this is that we have our electronic medical records to do the work for us, right? It's a lot of information. It's a lot of suggestions of ways that you can modify your EMR and variables and performance measures that can be monitored through your EMR. But the whole point is that your EMR is doing the work for you. And once you make those modifications so that your EMR is automatically tracking certain activities, so that your EMR is automatically generating and producing performance outcomes, once you do that, that's a full-time job in itself right there. You are not only optimizing your workflows, you are enhancing your screening activities, you are enhancing direct services probably for your patients and seeing better patient outcomes because they're receiving quicker results because routine testing is integrated as part of medical care for that patient. So we really want to use our EMRs to the best of our advantage, and if it's applicable, of course. Any other questions about quality improvement? Some quality assurance activities. We mentioned in this presentation that a good a strategy perhaps to really do some quality assurance, continued quality improvement activities would be to cross-reference supporting documentation and cross-referencing that supporting documentation with actual testing activities that occurred within the clinical site. So an example of that would include a patient's general consent to care, for example. That's a supporting documentation, right? Because that document is where we are, it sounds redundant, but that document is where we are documenting the patient's decline. We are also taking that decline, I assume, and that the general consent is integrated within the EMR. So it's all being documented within the computer system. So by integrating a general consent within an EMR workflow, you're able to automate testing and optimize it in a way that it's so routine that it's part of medical care. And so a way that the cross-referencing for quality assurance, quality improvement activities would be looking into those declined tests, those general consent to cares where the patient actually declined an HIV test, and making sure that an HIV test did not occur during that medical visit. Or you can try doing it the reverse way, looking into the HIV tests that did occur within your clinical site and cross-referencing those tests to make sure that there was no decline documented within the EMR, that there was no opt-out activities because the patient wanted that HIV test. So there's ways of cross-referencing your supporting documentation, all of which should be stored within your EMR. And there's ways to double check that to make sure that the testing activities are complementary of what is being documented and stored within the patient's electronic medical record. We have another question. Thank you, Pamela. How can we get buy-in from leadership to enhance or build out EMR platforms? That is a great question, and Amanda thinks so too. With all the measures they're required to report on, Amanda says it can be challenging to enhance or build out an EMR platform beyond that. Amanda, I hear you. So we all know that testing, it all starts at the top, right? We need to get the buy-in. First and foremost, we need to, from starting at the top, I would suggest not just looking into your executive leadership for buy-in, but I suggest reaching a little bit further and looking into your state legislation. Understand what the testing laws look like within your jurisdiction so that you can go back to your executive leadership and you can remind them, hey, in this state, we are permitted and allowed to conduct routine opt-out HIV testing within this clinical site. Why aren't we doing this? Or here's why we should be doing this. Or here are some of our partners or competitors who are doing this, and this is why we should be joining in and hopping on the wagon. So that's one strategy, is looking into your legislation and using that to leverage some buy-in internally within your executive leadership. So I would like to start there. I would also like to suggest of reaching out to other peers, other clinicians, clinical sites who are doing successful HIV testing implementation and also have similar prevalence rates within their communities, just like yours. Look, you can connect with me or our SIBA team, and we would be happy to connect you with other clinical sites who are practicing similar practice testing as you all are, and you can learn promising practices from those peers. You can learn lessons learned from those peers and almost get a jump start in trying to figure out what modifications need to be done so that when you do meet with your executive leadership, you have done all your homework, you have filled in all the gaps, you have thought of, well, if this doesn't work, then we should go to plan B, because you heard about those plan Bs or plan Cs from your peers. You heard what was going on and what has worked within the field. So reporting all of that back and doing your homework, knowing your data is huge. When you go to see your executive leadership and they ask you what your seropositivity rate, you should be saying that right off the top of your head. And your linkage to care rate, you should be saying that off the top of your head. We need you to be fluid and comfortable and confident with your data so that we can really sell what it is that we're trying to accomplish at our agency. Another strategy of obtaining buy-in from your leadership, and it's a little bit of a provocative strategy, but it was mentioned in the section in the presentation where we discussed missed opportunities. If a patient is presented within a medical system and they've been tested late in their HIV progression or AIDS progression, disease progression, they are tested late in their disease progression, but yet they had still visited that medical system 10 times that year, they could have been tested. There were 10 missed opportunities to test that patient. Think about those resources. Think about those resources that could have been saved by treating the patient for everything else besides just offering them an HIV test and getting to the source of that patient's medical condition and treating that. So kind of shifting it in a way, shifting your discussion almost to the way that money talks, right? That's another strategy of leveraging executive buy-in, or at least getting some attention and some ears, is speaking in terms of dollars. But of course, what we really want to do is make an impact in individuals and patients' lives. That's what we are all here to do, of course. So really humanizing your data, humanizing your patient case studies, and telling your executive leadership exactly what happened to a patient and what was going on with them at the time of their diagnosis, and why we were able to link them successfully to care, why we weren't able to link them to care as a result of gaps within our services. And here is a solution to filling in those gaps within our services: an electronic medical record. And here are some modifications that we can integrate within our EMR system to close those gaps within our services. So there's a number of different ways that you can leverage buy-in. There's some provocative ways, and then there's just some promising practices that we've picked up along the way, and thanks to hearing from our peers. We have 2 more minutes left in our session, and I would like to pause and take the rest of our questions that we have. We have one more question. How can health departments drive and support routine opt-out efforts within their jurisdiction? Pamela, that is a fantastic question, and I would like to take that question and respond to it in our next session, which begins at 11:15 a.m. Central Standard Time. And I welcome you to join. It's called Asking. It's an open table session, Asking the HIV Testing Expert, where we will have an authentic conversation, and folks will have the opportunity to ask any questions or provide any comments or feedback that they may have. And we will also be responding to Pamela's last question that's located in the chat box. Just as a reminder for folks, we will be having an evaluation link sent out to you all at the close of the symposium. And we will also be sending out links for those interested in continuing education credits, CEUs. We will be sending out links for an evaluation to be completed. So if you are hoping to receive CEUs at the close of this symposium, please stay tuned. A link will be sent out for you to complete, and the same goes for an evaluation. I would like to remind participants to please do a session evaluation by selecting the polls tab on your screen right next to that chat box, right inside the chat box. Select the polls tab, and if you could kindly complete that poll for us and let us know how we did today, that would be so wonderfully appreciated. And on behalf of the Midwest SEBA team, I would like to thank you again for joining us today's session. It is always a pleasure. Unfortunately, I'm not with everyone, but it is always a pleasure to be with everyone no matter what, to be with my fellow testing champions. And from the bottom of our hearts, we thank you for your continued support and dedication through testing and helping our communities and the epidemic.